patterns for presbyopic correction among ophthalmic surgeons while operating. So microsurgeries like ophthalmic surgery require an impeccable visual acuity, of which stereopsis forms an important component. Stereopsis is found to directly affect generic skills and intraoperative dexterity, and hence the surgical outcome. Presbyopia is known to adversely affect stereopsis, and therefore the surgical outcome also gets affected. So we decided to study the preference patterns for presbyopic correction among ophthalmic surgeons while operating. The objectives were to study the type of presbyopic correction used while operating and for checking patient records. We did a questionnaire-based cross-sectional study among 100 ophthalmic surgeons for a duration of 2 months, and information regarding age and gender, subspecialty, refractive error, duration of presbyopic correction usage, operative hours per week, refractive correction while operating, method to perform timeout, and stereopsis patterns were obtained. In the results, we found that majority of the surgeons belonged to the age group of 45 to 55 years, 45% were females and 55% were males. Among the subspecialty distribution, cataract surgeons and general ophthalmologists formed the major chunk. Presbyopia was the most prevalent refractive error, followed by presbyopia with simple myopic astigmatism and presbyopia with simple hypermetropia. Majority of the surgeons were using presbyopic correction for a duration of less than 5 years, and majority were high volume surgeons operating for about 5 to 15 hours per week. For presbyopic correction while operating, 61% preferred non-spectacle methods and 39% preferred spectacles. Among the non-spectacle users, 27 surgeons preferred to use eyepiece diopteric adjustment, and 33 surgeons did not use any correction while operating. Among the spectacle users, 32 surgeons used progressive glasses and 7 used monofocal glasses. For timeout, 54 surgeons used spectacles, 23 relied on OT staff, 5 used brick screen EMR, 16 did not require any correction to read, and one surgeon used magnifying glass as seen in this video. We also found that one surgeon does not perform timeout because of low surgical volume. For stereopsis patterns, 55% surgeons had never checked stereopsis, and among the 45% who had actually checked stereopsis, 51% suggested to have better stereopsis with microscope adjustment. On studying the stereopsis patterns in different refractive errors, there existed a statistically significant difference. So, coming to the discussion, over 50% of the cataract surgical load in the country is performed by the surgeons in presbyopic age group, and hence it is necessary to have a perfect refractive correction to gain high level of stereopsis and good surgical outcome. In a study conducted by Tuna et al., they concluded that presbyopia significantly diminishes stereo vision and hence influences the surgical outcome, and that surgeons with presbyopia greater than 1.25 diopters must always perform surgeries with proper correction. Similarly, in our study, we found that 60% of the surgeons had presbyopia of more than equal to 1.5 diopters, and 67% surgeons were using some form of refractive correction for presbyopia. Garnham and Sloper concluded that there is mild decline in stereo acuity with age, which is more significant above the age of 55 years, hence periodic testing is necessary. In our study, only 45% surgeons had checked stereopsis, among which 5% reported absence of stereo acuity, and only 27 surgeons had done so in last year. We also found that 40% surgeons preferred non-spectacle methods, which can be attributed to the low symmetrical refractive error. 60% suggested to have better stereopsis with microscope, and 50% were using presbyopic glasses for less than 5 years and hence were considered to be inexperienced. So to conclude, majority of the surgeons suggested to have better stereopsis with eyepiece diopteric adjustment, but practically only 1/3 preferred to use eyepiece diopteric adjustment, 1/3 did not use any correction to operate, and 1/3 used spectacles. For surgical timeout, majority of the surgeons preferred to use spectacles. 55% surgeons had never checked stereopsis. This highlights the importance to increase awareness regarding periodic testing of stereopsis by the ophthalmic surgeons, for which we would like to suggest a device to check stereopsis intraoperatively and a scoring system for grading stereopsis in near future. These are my references. Thank you.
You didn't test stereopsis in any of them?
No, ma'am. It was only a questionnaire-based study. We did not do any objective testing. Thank you.
What did you recommend now? Whether they have to go undergo stereopsis test before doing surgeries?
Yes.
All surgeons you recommend to go for stereopsis test.
Yes, sir. Periodic testing is necessary. Like exactly.
Thank you.